way.
Sorry.
So Eric, go back a little bit.
Yeah, yeah.
Eric's taking over the
Oh, okay.
some dire straits.
Yeah, he's the rescuer.
There was never anybody there. So.
I'm introducing her.
Yeah, right here.
Thank you. You're going to get them right.
Dr. Buhai.
Oh, Dr.
Yeah.
Somebody's.
I don't have any podium time.
At all?
No.
So it goes from you to her.
Correct. Correct. I think she's got the agenda. So yes, the video's good to go. Sound and all.
Not even the same country.
Okay, should we get... Are we ready? Okay, we're going to get started. High for me. Little too high for me, sorry. Good evening, everyone, and welcome to the last of our speaker series for 2018. This is a speaker series that is being held by the Student Success Fee, or supported by the Student Success Fee program at SDSU, and our amazing graduate student council, led by Benjamin Schumacher, who we appreciate their efforts tremendously in making this an incredible experience for the rest of their student cohort. And with us tonight is going to be, we have faculty, students, alumni, and I know a number of people on our live web stream. I am going to turn the time to our student council rep, Caitlin Cole, to introduce our speakers, and we hope you enjoy the rest of this evening. Oh, a little bit taller than Dr. Manat. Thank you for the introduction. So I'm going to introduce Rigoberto Vargas, our first speaker. Rigoberto Vargas has been with the Ventura County Health Care Agency for almost 20 years, holding a variety of positions in the Public Health Department. He has been serving as the Public Health Director since April of 2013. He currently oversees the department's many programs that promote wellness and prevent disease. During his tenure, Ventura County Public Health has been awarded several local, state, and federal grants. In June of 2014, Ventura County Public Health achieved national accreditation through the Public Health Accreditation Board. Ventura County Public Health was the first department in California and among the first 50 in the nation to earn this important distinction. He holds a bachelor's degree from UCSB and a master's degree in public health from SDSU. Rigoberto resides in Oxnard with his wife Veronica and their two boys, Tizak and Izel, ages 9 and 11. Please welcome Rigoberto Vargas.
Thank you, Caitlin. Good evening, everyone. And thank you, distinguished guests or folks that are here this morning, or this afternoon. I particularly want to thank the Student Council for setting this series up. Also appreciate the faculty and staff that make this lecture series possible. It's a pleasure to be back on campus. I had the opportunity to have a wonderful dinner with colleagues and also walk around the campus. And in 25 years, it sure has changed, but it's still a beautiful campus. It's still a beautiful campus. So I'm really honored to be here to share a few thoughts around Latino health issues, and also hopefully time will also allow for a little bit on my career trajectory. So with that, let's see, we'll use the arrows. Okay. Oh, so we have some competing presentations here outside. So this is a brief outline of what I hope to cover today. So several points, and I hope to, again, in the next 30 minutes or 40 minutes to cover these. First, in terms of disclosure, I'm here based on, to present research, the review of the literature that I've done on my own, so I'm not here in the capacity as Public Health Director for the County of Ventura. And again, it's a pleasure to be here with you. So I'll cover a little bit about the latest Latino demographics. I'm going to focus in, especially around when we talk about health equity issues in any group, including Latinos. It's important to start with, I believe, a discussion of social determinants of health. I'll touch upon health disparities and inequities. I'll show a short video clip, a 4-minute or so video clip on the topic of how a place where you live matters so much to one's health. Then lead into the Latino health inequities, and then highlight some key efforts and strategies and partnerships that county health departments are embarking in order to really change the health of communities. So that's my presentation outline. First is Happy National Public Health Week. Hopefully all of you guys were aware that every year the American Public Health Association sets the first week of April to celebrate the great work that public health colleagues, researchers, professionals throughout our beautiful nation to honor the work that we do and to bring attention to the work that needs to be done to have a healthier nation. It's interesting that I think for the last several years, American Public Health Association has selected as one of its theme, an ongoing theme, Healthiest Nation, and Healthiest Nation 2030 in particular. But why the Healthiest Nation theme? Aren't we the healthiest nation? After all, don't we spend the most or among the most compared to other industrialized countries in terms of our costs? Aren't we the healthiest nation? And so even though in the U.S. we spend more than 2 times the amount of other industrialized nations in terms of our healthcare expenditures, our health outcomes are not the best. In fact, on important health outcome measures such as life expectancy, the U.S., as you may know, actually ranks among the bottom of the industrialized nations. We rank in particular, I found, I think we moved to 34. Our ranking is 34, and we spend the most. So I think what the American Public Health Association is trying to do is bring further attention to our challenge as a nation, as a state, and in my case, at the county level, that we need to strive towards making our great nation the healthiest. If we're spending so many resources, there is no reason why we should not be among the leaders with regard to health outcomes. Not all of my slides are going to be as busy as this one, but I did cut and paste this diagram that shows also a couple of the themes that I want to touch on today, but it has to do with the county health rankings. As you may know, these are also rankings that come out on an annual basis, and it provides a measure on how counties nationwide are doing towards meeting the national goal of Healthiest Nation 2030. And so what I find interesting, is probably hard for you to see here, but in my later slides, it'll break down some of this information. This slide basically shows how these national health rankings are pretty much ranked in 2 categories, health factors and health outcomes. Both of these are influenced by the context of our communities, the policies, the programs, really the systems and the environmental context that makes these health factors and health outcomes possible. But in particular, I want to draw your attention to the middle part, the health factors. The health factors are determined by 4 areas, 4 risk factors, and each of them get a weight or a percentage. And to draw the attention to the particular theme about social determinants of health, I want to draw your attention to the fact that clinical care, our healthcare system, actual going to the doctor and to the clinic, and our medical system, our medications, that in the national health rankings gets a weight of 20%. 20% is to clinical care. But that's as opposed to social and economic factors. That factor gets a 40% weight. So really, and what makes up the social and economic factors? It's the social determinants of health, such as education, employment, income. These are the true drivers of health and have the largest impact on our health. Sure, individual behavior is important. Those get around 30% of the weight. Clinical care got the 20% I mentioned, but the largest weight in the rankings is social and economic factors. 40% of health factors are made up of social and economic factors, and those are the largest drivers of our health outcomes. Health outcomes meaning quality of life and length of life. So that busy slide, but again, introduces the fact of the importance and the weight that social and economic factors have in our health. A quick word about the changing demographics in terms of the health of our community. So you see here, this compares the projections of our country comparing the two largest racial ethnic groups, Latinos and non-Latino whites. So you see that in California, by 2060, where Latinos are projected to make almost 1 out of 2 Californians will be Latino, and that's an increase from about 36 at this point. However, in California, non-Latino whites are expected to decrease to 30% of the population. In a similar pattern at the national level, where Latinos are expected to increase from about 18% currently to almost 30%, and Latino population, the white population right now in the United States, it's estimated to be around 61%, and by 2060, it's projected to go in the opposite direction of Latino community and go down below 50%. So these are, I think, important changing demographics that has large implications for the health of our nation as a whole, and so that's why I think it's important to continue to focus on the attention of all racial ethnic groups, but especially Latinos in this state. So a little bit more about actual social determinants of health. Simply put, social determinants of health are the conditions and opportunities where we do these main 4 things: where we live, so our neighborhoods, our communities; where we learn, so our schools and our school system; where we work, types of jobs, are they full-time, how much do they pay, do they have sick leave, do they have family leave; and where we play. So is our neighborhood safe? Are there parks? Are there safe streets? And these are really the conditions that have and the factors that have the most impact on our health. So as an example, when it comes to life expectancy, these 4 areas have a significant impact on our life expectancy. Again, life expectancy being one important measure of the health of a nation or of a state. So for example, based on where one lives, there could be as much as a 20-year life expectancy difference. This has been studied throughout the United States, in California, and even in our own Ventura County, where I come from. There is significant life expectancy difference based on where you live, simply where you live, and the conditions of that community. Another important factor is education, and what kind of education, and is there educational attainment, and that can create a difference of 9 years for those that don't graduate from high school and those that go on to higher education. Income is a great predictor of health, and that can account for as much as 10 years difference between those that are barely getting by to those that are more well off. And race is an interesting one. There's also been great differences found in life expectancy by race. But it's interesting in particular because when it comes to most races, whites have bigger or larger life expectancy, but as compared to Latinos, actually it's the opposite. Latinos have a higher life expectancy than non-Latino whites and other racial groups except for Asians. So there's going to be a little bit more information on why that might be in terms of the life expectancy difference among Latinos. Before I go a little bit further in terms of this topic, I just want to draw attention to this pyramid that I found interesting and I took from other researchers and publications. So which interventions have the largest impact? So at the top of the pyramid is some of our traditional healthcare system focus on counseling, education, clinical intervention. All those are going to have an impact, but not as a significant or large impact as the bottom of the pyramid. There's always going to be a room for and importance of getting good quality clinical care, medications, doctor visits, education and counseling. But it's really the long-lasting protective interventions that are more in the middle of the pyramid, such as immunization campaigns, smoking cessation programs, that will start to have increased impact on our health. And making it further down to other areas that have largest impact on our health are those that are actually policies, systems, changes, making the the healthy choice the easy choice, making it natural for one to live a healthier life. So maybe those include smoke-free laws, seatbelt laws, where, again, through policy and through laws, those have had a significant impact on public health. But more and more attention is now being placed on at the core bottom of this pyramid. It's these social and economic factors that I mentioned earlier that really have the largest impact on people's health, not just Latinos, but the larger community. And those examples include education and income. So in doing some of this research, I found that generally we can put these important factors that influence health into two categories. The first have combined about 50% influence on our health outcomes, on how long we live and how well we live. So that includes healthcare, our family history, our genetics, and our individual and personal behaviors. All those combined have about 50% influence on our health. The other 50%, though, are the larger systems, policy, and environmental changes that are needed. These include our physical or built environment, how safe is our neighborhoods, are there opportunities for walking, for biking, what are the environmental conditions, how's our water quality, our air quality, and then those social and economic factors. Are there jobs, are there well-paying jobs, how are our schools, systems, and supports? And those three last factors make up the rest of the 50% that really influences our health. So what really we need as a nation, as a state, and in our county in Ventura, we really are trying to transform our community, transform our healthcare system to where we change these conditions where we work, learn, live, and play. And what do I mean by transformation? We need big changes to happen where we work, where we learn, where we live, and we play. So for example, in the income area, there's a lot of communities that are putting more attention about increasing the minimum wage, living wage campaigns, making work sites or employers have additional social type of benefits where there's family leave, sick leave. Those kinds of efforts are really going to have a significant impact on our health. Education goes hand in hand with good health, and so we really need to continue to promote higher education. So I'm glad to be at a setting here in an institution of higher learning, but we need to have those opportunities for everyone to have a higher education. Their chances of having a good paying job that will have benefits and allow them the means to be able to afford good, healthy lifestyle is dependent on good education for good jobs as well. Housing is very important to one's health, where we live. We saw the life expectancy differences earlier, and so our housing needs to be safe and affordable. And as an example of what needs to improve with our environment is to have perhaps more green space, more parks, and more recreational opportunities for children, for middle-aged folks, and for our seniors. In Ventura County, we did a strategic planning session a few years back, and we adopted this model of a healthy community. Basically, it draws attention that at the core there, health outcomes, what we really want to establish is good quality of life, have good disease and death outcomes, and increase life expectancy and the quality of life. But in order to do that, yes, it's important to focus interventions on the individual. There's always going to be individual responsibility and need for healthy lifestyle, but it's the context of that health, the healthy social and physical environment that is going to be conducive to those messages that you give to the individual or the family. And ultimately, in order to have a healthy community, we need some systems and policy and environmental changes. I think the screen up there went off. Mine's still on, so that's a good. And in order to have a healthy community in Ventura County, we're focusing on having some interventions, some policies. So for example, I don't know if you guys have heard of the Health in All Policies framework, where basically health departments are urging other sectors such as law enforcement, planning, maybe water and air departments and units to when they pass policies or they pass laws, for them to consider the health impacts of those other sectors, and to always have a health lens when we make decisions. And key to a healthy community is health equity, looking to address the social determinants of health. At Ventura Public Health, we recently came out, in fact, 2 weeks ago, with the Community Health Improvement Plan as part of our accreditation efforts. And we've focused our Community Health Improvement Plan on these 5 areas that are pretty much aligned with state and national efforts that are aligned with the Healthiest Nation initiative. In California, we have the Let's Get Healthy California initiative, and they pretty much outlined these 5 goals that we're adopting at the local level. So we want to support healthy communities. We want to support healthy beginnings with our children even before they're born. We want to promote wellness at all ages and stages, including aging well, aging healthy. And we, of course, need to focus on a healthcare system that is not so focused just on sick care, but instead is really focused on health and really on well-being. And so we're focusing our community health improvement strategies around these 5 goal areas. So now I'd like to turn a little bit more into actual health equity concept and health disparities. Oftentimes we hear about health inequities and health disparities. More and more public health departments and public health professionals are focusing on health equity. And simply put, health equity is achieved when everyone is given the opportunity to reach their full health potential. So everyone is given the opportunity. So they have the resources, the access, the supports needed to reach their full potential. And it's important to distinguish equity versus equality. So in this diagram, you see folks at an orchard perhaps reaching for an apple. And so equality would be to have the same support for each of the 3 individuals here, regardless of their size or their circumstances. But equity would be for, say, the shorter person that perhaps needs additional resource or help to reach, in this case, an apple, or in another larger example, reach the full health potential. They might need a little bit more in terms of resources and supports. And that's really what health equity is about, is giving everyone the opportunity to reach their full potential. So as opposed to health disparity, as simply put, is a difference in health outcomes. So oftentimes we hear about health disparities, health inequities, health equity, and I just wanted to simplify it for you here and put it simply that disparities are differences. There's always going to be differences in the health outcomes, right? There's going to be, sometimes children are going to have certain diseases as opposed to older folks. Sometimes there's certain diseases that are more common among men versus women, and sometimes by race. But when those differences are due to unjust and unfair conditions, and when those differences can be preventable or controlled, then it's inequity. There's an equity issue there. So again, the inequity is a type of disparity, and it's a disparity where it could be preventable, and it's an unjust and unfair difference. And that really gets to the place, to the topic and theme in public health, which is place matters. I mentioned how there's different life expectancy outcomes in different populations of Ventura County. One of our lowest income communities, zip code, has a 76-year life expectancy, whereas a more affluent neighboring 10-minute drive community has a life expectancy of 88. So just where you live can have a health impact. So to further demonstrate this, I'm going to attempt to show you this 4-minute video clip that brings further attention to the topic.
What determines how long we'll live? Is it what we do? Is it?
Sorry. There it is.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, B-Ville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway. And for food options, Maria's only choices are B-Ville's many liquor stores, fast food places, and convenience stores. The schools in B-Ville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of B-Ville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and B-Ville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and B-Ville are so unequal, B-Ville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in B-Ville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow. We lead. We are building the power to make health happen in communities across the state. We are coming together to build one California, a smarter, more inclusive and equitable state that creates health and opportunity for all of us. Join us. To learn more, visit buildinghealthycommunities.org.
Thank you, Benjamin. So I thought I'd share that California Endowment video that visually, graphically demonstrates some of the concepts that I've been touching on in terms of social determinants of health and health inequities. So a little bit now turning into the actual overview of Latino health issues. So the good news is that overall Latinos fare well in many areas, but there are some interesting trends that are coming about. So for example, in cancer, even though Latinos have a lower mortality and morbidity than whites, cancer is still the leading, now the leading cause of death, whereas heart disease is still the leading cause of death for most Americans, but for Latinos is now cancer. So there's a trend there. Also, diabetes for years has been a significant health issue in Latino communities, where showing some studies showing as much as 2 times the rate with Latinos compared to non-Latino whites. Obesity is literally an increasing issue in all communities, including and especially with Latinos. Some studies have shown Latino children to be as much as 5 times at greater risk for obesity. And all of this is leading to increased chronic disease risks for Latinos. Chronic disease as it is, it's already a significant health issue in our communities. Chronic diseases, diabetes, heart disease, cancers, those kinds of diseases are the leading cause of premature death. They account for the majority of all deaths, and they're significant drivers of our healthcare system. As much as 70% of all health expenditures are to treat chronic diseases. So this is going to be an ongoing challenge. Chronic diseases are for Latinos as with all other groups. This is a busy slide, but I just want to quickly draw attention to the leading causes of death comparing nationwide Latinos to whites. And it's hard for you to see the 3 areas in red that I want to draw your attention. So there it shows cancers being the leading cause of death. The latest data that I found was for 2015. Cancers, leading cause of death for Latinos. But as I mentioned earlier, it's still diseases of the heart for whites. Diabetes is the 5th leading cause among Latinos, but 7th for non-Latino whites. Then another interesting thing to take from the leading cause of death comparison is that chronic liver disease and cirrhosis makes it to the top of the 10 leading causes of death, namely number 7. But that disease, those diseases actually are not among the top 10 in non-Latino whites. So those in particular stand out when we look at Latino health issues. But there's, if you done some research in terms of Latino health issues, you may have come across the Latino health paradox. And there's some debate about if such a paradox exists. Paradox simply means, something unexpected. And so the unexpected aspect of Latino health is that in spite of traditionally and historically, Latinos been in the lower socioeconomic status in our community, lower income, lower educational attainment, higher poverty levels. So you would expect perhaps worse health outcomes. But when it comes to life expectancy and even some chronic disease rates, Latinos actually fare better. So that perhaps is a paradox. Why is that? And it also not only is characteristic when it comes to life expectancy, there's also Latinas, Latino mom in general have better health outcomes than non-Latinas. And this brings me to a third point about Latino health, and that is acculturation. Acculturation is the study of a culture and its influence on health outcomes. In fact, when I was at San Diego State, my thesis topic was around acculturation. And so acculturation seems to still have an effect where these better birth outcomes among Latinas, well, they're particularly more common around new immigrants. Immigrant moms generally have better health outcomes. You wouldn't necessarily expect that. And so acculturation, in fact, is basically that the longer Latinos live in the United States, generally they tend to have worse health outcomes. Not always, but in general, moms have worse health outcomes for their babies the more they've lived in this country, later generations. And also some of the risk factors like drug use and obesity and other chronic diseases are higher among second and third generation versus recent immigrants. So these are important health topics that need continued research. I'm going to conclude my presentation with a few slides showing you the latest data that I found with regard to Latino health inequities. These are going to be data around poverty, education, and health coverage. First, in terms of poverty, using a conservative measure of poverty, this slide shows, let's just focus on the California versus U.S. comparison. So the yellow, or actually green, well, mine is green, and up there it's more of a yellow color. That is for Latinos, and you see that Latinos have a much higher poverty rate in California than whites, and similar trend at the federal, national level. Latinos have much higher poverty rates than whites. And this is using kind of I would say, a traditional and perhaps conservative measure of poverty. When we look at other poverty measures, such as there's the United Ways of California came out with a newer and different, and I think more accurate measure of poverty. They call it the real cost measure, that pretty much takes into account the living conditions of a particular community, so how much it costs to go to school, for childcare, for transportation costs, what are the unemployment rates, and how other challenges in that community, and they give it a score or a measure for poverty. And using that figure, it shows that as much as half of Latinos in California are living in poverty, and as many as 15% versus the 10% of non-Latino whites are living in poverty. So, yes, the real cost measure, and again, that's why I like that measure. I think it's more accurate. It does take housing costs, transportation costs, educational costs, and other factors. So that was with regard to income and perhaps some inequities and inequalities regarding income. So with regard to education, I mentioned is so key to the health and well-being of our nation, of all groups, but including and especially Latinos, given that we have Latinos with lower educational attainment. If you focus on the comparison between California and U.S. for Latinos, you see that 6 out of 10 Latinos graduate from high school, so as much as 4 Latino students do not finish high school, and that compares to only about 6% of non-Latino whites not finishing high school. And this is at the state level. A similar pattern exists at the U.S. level, with Latinos students having a much lower completion rate of high school than their peers. In health insurance is another measure of perhaps health inequities and inequalities. Also comparing just the California versus U.S. figures. The Affordable Care Act has increased health coverage. It hasn't controlled very much in terms of costs if it wasn't for the subsidies and the expansion of Medi-Cal, but nevertheless it has had a significant impact on health coverage rates. So Latinos in California, their health coverage rates have increased to 80%. That is better than at the national level. Because not all states have expanded their Affordable Care Act efforts, but those are still lower than their peers. You see that the much higher bars for non-Latino whites when it comes to health coverage. The next 2 slides real quick is on the actual health issues that perhaps the disparity a little bit more in terms of obesity. This is just for 5th graders. An indicator of overweight and obesity for 5th graders using FitnessGram data, outside the healthy fitness zone. It shows that as many as 50% of 5th graders that are Latino are already overweight. And even though this is Ventura comparing to California, and even though white students have much lower rates of obesity, nevertheless, when 1 out of 5 students, even they're non-Latino and they're white, even then I think it's a very high rate. 1 out of 5 non-Latino whites are overweight already in 5th grade, and 1 out of 2 Latino students. Adults are not doing much better at the county, state, or local level. Latino adults have much higher obesity rates than their peers. And when it comes to diabetes, not surprisingly, Latinos in California have significantly higher rates of diabetes, and also in the U.S. So I'm going to go real quick. I'm going to conclude my presentation with just highlighting the importance of strategic partnerships and efforts that are really seeking new and non-traditional partnerships in order to address the social determinants of health. So, for example, in Ventura County, our county health department is actively engaged with a new coalition, the Family Financial Wellbeing, that looks to promote economic development and literacy, and other efforts that are going to help families to move up the economic status and get better jobs. So we're at the table promoting economic development. So perhaps this is a different area than traditional partners, where health professionals usually partner with schools, with not-for-profit organizations, with hospitals and clinics, but not so much with economic development organizations. In terms of education in our department, our own employees come up with a Lead, Walk, and Talk campaign. They come up with the name themselves, and that campaign seeks to draw further attention that as public health professionals we need to be leaders and embrace the role of Chief Executive, Health Executive. Chief Health Executive is a new term that's being thrown around at the national level around the role that public health professionals should embrace in terms of being leaders and engaging non-traditional partners. So we want to be leaders in those efforts. We want to walk the talk. And literally when we talk about talk, is not just promoting health, promoting messages, but also encouraging reading and learning, especially before the age of 5 when a significant brain development is taking place. So we're expanding our efforts to work with First 5 in our community. We've also partnered with housing departments to hold a health and housing summit that was very successful, engaging folks from both sectors about the interconnection between health and housing conditions. We're also partnering with the Hospital Association of Southern California on their Communities Lifting Communities initiative that seeks to end or at least address homelessness, poor birth outcomes, and high diabetes rates. Finally, in Ventura County Public Health, we've really embraced our role to be at the table when it comes to general plans to make sure that when cities are making decisions around land use and planning, water and air, and climate change, that public health is at the table making those decisions and providing information and education. But my final slide has to do with a couple of pictures just showing about how important it is to engage the community for building a healthy community. The first picture on the left shows a group of moms where our health educators held a series of nutrition education classes where we taught them traditional healthy recipe cooking, supermarket tours. But then the moms, and actually there was grandmas and children in that cohort, and they said, fine, you did a 6-week class series with us, but now what? We see that in our low-income neighborhood, we don't have safe walking paths. We don't have a garden. And so we engaged them in additional training where they themselves were able to get the local city council to designate land for a park that had rubberized walking path. They also organized walking walking groups in the community, and they themselves were able to get an empty lot designated as a community garden that brought a lower income neighborhood that they lived in along with their neighbors in a newer neighborhood to come together and do gardening, and then to also try to help back the community by engaging in food distribution efforts. So this was just one example of how we need to transform our communities to promote health among Latinos, and not just Latinos, but for all populations. We need to strive towards health equity, and in order to do that, we must expand our efforts and partnerships that address the root causes of health. And again, these root causes of health, there's always going to be individual responsibility, but it's really the social determinants that are going to have the largest impact on our health. And so with that, I'll stop here. I was going to touch a little bit about on my career journey, but perhaps after the next speaker, if there's time, both of us could touch a little bit about our career paths and our journeys since being fellow Aztecs and what our careers have been since then. Thank you.
Thank you, Mr. Vargas, for that presentation. I also wanted to thank Dr. Madna and Dr. Buhai, who are our student council advisors, for helping us to submit this student council success fee and to get the funding for this great speaker event. And to all our attendees across these 3 events, we've really enjoyed hosting it as a team. So I'm going to introduce Umberto Monge. Sorry, my accent is terrible. So Mr. Monge served 27 years in the Navy in Operation Desert Storm and Operation Iraqi Freedom. His education began when he received his BHS with honors at SDSU in 1987. He then proceeded to graduate from the Primary Care Associate Program, the Physician's Assistant Program at Stanford in 1989. After this, he received his master's degree in Physician Assistant Studies with an emphasis in surgery from the University of Nebraska in 1999. Umberto was the first physician assistant to be credentialed and given privileges to practice at Lucile Packard Children's Hospital and Stanford University Hospital. Currently, Mr. Monge is the Senior Physician Assistant for the Department of Surgery and the Abdominal Organ Transplant Program at Stanford Hospital and Lucile Packard Children's Hospital at Stanford. He is a member of the Quality Assurance Committee of the Abdominal Transplant Program, as well as a member of the Interdisciplinary Practice Committee of the Medical Board at Stanford. He is the founder of the Umberto and Eileen Monge Scholarship for students in the field of health and human services at San Diego State University. Lastly, he has co-authored numerous journal articles and abstracts and has lectured in many local and national meetings in the field of transplantation and has received numerous awards for his teaching, mentoring, and medical expertise. Please join me in welcoming Mr. Monge.
Good evening, everyone. It's a pleasure being here at San Diego State. The changes here are just amazing. When I was a young man, I joined the Navy, and at that time, the commercials that were on TV said, the Navy's just not a job, it's an adventure, and I was hooked. I became a hospital corpsman, and then I went to further education and became a surgical technician. And with that, they sent me on board the aircraft carrier USS Midway, which was home-ported in Japan. And as you know, it's a floating museum out here in San Diego Harbor. That's how long ago that was. In any event, while I was on board the USS Midway, the Navy surgeons I worked with would always tell me, to better yourself, you should go to college. And so I took their advice, and I took quite a few college courses at sea. And for the college professors that would come on board, I'm sure it was a Navy adventure for them, because we always enjoyed watching them come off those planes that would land on the aircraft carrier and look at their faces and see how long it took them to take their sea legs, because it was really funny watching them. In any event, once I finished on board the USS Midway, I was transferred to the USS Acadia, which was another ship home-ported here in San Diego. And towards the end of that tour, we ended up going on a 6-month cruise to the Western Pacific. During that cruise, I applied to San Diego State. And at the end of the cruise, as we were heading back to San Diego, I received a letter from San Diego State saying that I was not admitted. I was not waitlisted. I was not nothing. The hard part of that was I had nothing else to do in the middle of the ocean but think about what was I going to do next. I was at the end of my enlistment of the Navy, and I was heading back to shore. And all I thought about was, should I re-enlist? Should I just forget about it and get a job? Should I go to community college and then wait to reapply again? And right before we were about to land into San Diego, I got another letter from San Diego State. And that letter said they reconsidered, and I was admitted to San Diego State. In the 120 years that San Diego State is an institution of higher learning, I believe that was the smartest decision they ever made. They gave me an education, and they gave me the tools to open doors and walk through those doors so I could follow my goals as a physician assistant. I've been a physician assistant now for 25 years in the field of transplantation. And the field of transplantation has been met with many challenges. And one of the biggest challenges is the organ donor shortage. And that challenge still exists today. So today, I'm going to talk about that organ donor shortage and how it affects liver transplantation specifically, and how it's intertwined with some of the public health challenges that affects America today. To begin with, I just want to say I have no conflict of interest, and this lecture will be given without bias. So first of all, let me give you some background. The United Network of Organ Sharing, UNOS, is a private nonprofit organization that sets policy and manages the organ allocation and the transplantation of those organs in the United States. The Organ Procurement Transplant Network, OPTN, facilitates the allocation of organs and the transplantation of those organs in the United States. And by facilitating this, they have divided the United States into regions. We in the state of California are in Region 5. And Region 5 is made up of 5 states: Arizona, California, Utah, Nevada, and New Mexico. And within each state, there are OPOs, Organ Procurement Organizations. And those OPOs are the ones that evaluate the donors, assist in retrieving those organs, and they allocate those organs specifically to the patients at the transplant institutions within the OPO. So in Region 5, there were over 1,100 liver transplants done in 2017. Unfortunately, 238 people died waiting for liver transplants, and another 230 were removed from the transplant waiting list. And they were removed for multiple reasons. It could have been that they were too sick to be transplanted, or they may have developed a cancer outside of their liver that precluded them from being transplanted. Along with that, there still was over 3,000 people waiting to be transplanted. So who gets transplanted? Well, this pie chart has been the same for decades, up until recently. So number 1 is still hepatitis C. Number 2 has been hepatitis B, but no longer. Hepatitis C is no longer number 2 for a number of reasons. It's from better childhood screening, hepatitis B vaccines, better hepatitis B medicines, and improved screening of blood donors and improved screening of organ donors as well. But along with that, there is now non-alcoholic fatty liver disease. It is now the second leading cause for liver transplant and moving quickly higher. It's been strongly associated with obesity, metabolic syndrome, sedentary lifestyles, and increased caloric intake from glucose, fructose, and saturated fatty acids. And it's projected because of the childhood obesity epidemic that's existing here, that by the decade of the 2030s, it will be the number 1 cause for liver transplantation. So how do we transplant patients? So when someone gets evaluated and gets put on the liver transplant list, they get a MELD score. Now, MELD score stands for the Model for End-Stage Liver Disease. What happens is you take the serum bilirubin, which reflects the function of the liver. You take the creatinine, which reflects the function of the kidney. And you take the INR, which reflects clotting factors. And you put that in a formula, and out comes a number. And that number is your MELD score. So the MELD score moves up and down depending how sick or healthy you are as it reflects those numbers. In certain instances, you can use the serum sodium, the fact that you're on dialysis, or in certain strict criteria, the fact that you have a liver cancer to enhance your MELD score. And your MELD score goes up as you get sicker, and your MELD score comes down as you're healthier. Now, UNO set forth a policy called Share 35. And Share 35 means that if your MELD score gets to 35 or above, which means you're pretty sick, that you can share organs across the region, which means if I have a MELD score of 38 and I'm in Northern California at my transplant institution, but there's an organ in Utah that matches my blood type, and I'm at the top of the list, that organ from Utah will come to me in Northern California and will not stay within the OPO of Utah. UNO set forth that policy to try to avoid people dying on the transplant list waiting for a transplant or having to be removed because you've gotten too sick. Now let's talk about different types of livers. So the first type of liver we use to try to get over on this donor shortage are live donors. And live donors are friends, relatives, good Samaritans who are willing to donate. And these live donors are used for patients who are relatively healthy with lower numbers on the MELD score. And this is to try to avoid people waiting and waiting till they're too sick to be transplanted. So this population gets transplanted sooner rather than later. The next two types of livers are those who meet brain death criteria. The first one is split livers. And those livers under certain criteria can be cut, where a smaller piece is used for a baby or a small child, and the bigger piece is used for a larger person. That way, two people can get transplanted with one liver. The next one is the DCD liver. DCD stands for donor after cardiac death. Now these livers are livers that do not meet donor brain death criteria. These people may be having irreversible brain damage, or may have a terminal cardiac or lung illness, or other types of terminal illnesses, where they or their family have agreed to withdraw support and they wish to donate their organs. These patients or these donors will go to the OR, support is withdrawn, and if they expire within 30 minutes, we can retrieve their organs and use them for transplantation. The next two organs, the Hep C positive donors and the increased risk donors, have now become higher because of the opioid and the IV drug abuse crisis in America today. So let me first talk about hepatitis C. Now, in the 1990s, the main reason people got hepatitis C was from blood transfusions and from liver transplants or other type of organ transplants. That is no longer the case. Hepatitis C over the years was slowly coming down, or the incidence of getting infected with hepatitis C was coming down, and that was because of improved nucleic acid testing in screening blood donors as well as organ donors, needle exchange programs which are sporadically throughout the United States, the approval of hepatitis C drugs that are now new to the market, and liver transplant. Previous to these past few years, we did not use hepatitis C positive donors, but now we do because of the new drugs that have come to market, which are up to 96% effective in clearing the hepatitis C virus. So what do? So when patients get evaluated and placed on the liver transplant list, at the time of them being placed on the liver transplant list, we talk to these patients about the potential of receiving a hepatitis C positive donor. As they start moving up on the transplant list, we again talk to them about the potential of receiving a hepatitis C positive donor. And we do this because if they get a call at 1 or 2 in the morning, they understand about these donors and they can make a decision in a reasonable amount of time so we can proceed with retrieving the organs for transplant. If they agree to transplantation, what we will do is we'll take a biopsy of the liver before or during the retrieval of the organs just to make sure the hepatitis C has not damaged these livers. And if they have not damaged these livers, we will use them for transplant. In the postoperative period, we will check the genotype of the hepatitis C of the liver we transplanted. And that way we will know what type of hepatitis C they have. And so we can tailor the treatment of the hepatitis C drugs to the type of hepatitis C we transplanted. And postoperatively, our transplant hepatologists follow these patients very, very closely. Now, just in terms of numbers, now there are between 2.7 and 3.9 million people infected with hepatitis C. 75 to 85% with acute hepatitis C now become chronically infected. 60 to 70% develop liver disease in the form of ascites, encephalopathy, or GI bleeding, or other sorts of complications. 20% develop cirrhosis, and 5% die from liver cirrhosis or liver cancer. And 19,000 die annually from hepatitis C-related illnesses. In terms of increased risk donors, now increased risk donors are donors that do not have hepatitis C, hepatitis B, or HIV, but they've engaged in increased risk behaviors or have undergone increased risk procedures. And this could be people who have recently received a blood donation, people who undergo hemodialysis, commercial sex workers, or those who have died with IV drug abuse with sharing needles. The problem with them and what becomes increased risk is, even though NAT testing is very, very good, it still may be too short of a window for them to become positive. So there's an unknown there, whether they may convert positive or not for hepatitis B, hepatitis C, or HIV, and that is the increased risk. So what do? So again, just like hepatitis C, we talk to the patients who have been evaluated and placed on the transplant list about these types of donors. As they move up on the list, we again talk to them about these types of donors. If they decline this type of donor or the hepatitis C positive donor, we abide by their wishes. They do not get penalized, and they do not lose their place on their liver transplant list. That is their choice, and we honor their choice. But if they accept using an increased risk donor, we will proceed with the transplant. And in the postoperative period, during specific periods of time postoperatively, we will check for hepatitis C, hepatitis B, or HIV. In all the years that we've been doing transplant and using these increased risks, we have not had one patient convert to any of these viruses. Now, in terms of the increased risk, this is what we have today with the opioid and the IV drug abuse problem. 11.5 million misuse opioid prescriptions. A little over 2 million have an opioid disorder. 42,000 people died in regards to this in 2016. And deaths from prescription opioids have quadrupled, and the numbers keep going up since 1999. And currently, approximately 116 people die every day from opioid and IV drug abuse. The last thing I want to mention about this is that the Department of Health and Human Services has put forth 5 major priorities in trying to combat this crisis. And those priorities are the improved access to treatment and recovery services, promoting use of overdose reviving drugs such as Narcan, better public health surveillance, especially in communities hardest hit like in Ohio and Pennsylvania, cutting-edge research on pain and addiction, and advancing better practices for pain management. And as you may have read or seen in the newspapers or heard on the news, the White House has also put forth their agenda in trying to combat this crisis. And it'll be important to see how this pans out over the next few months and years. And what I last would like to say is, in using these types of donors in trying to improve the donor shortage, we have been able to increase the number of liver transplants we've done in 2017 by 40%. So this is a significant amount in trying to do this. And unfortunately, the opioid and the IV drug abuse problem has contributed to this. And finally, what I just would like to say is I'd like to thank Brian Schumacher for inviting me to come here, and I'd like to thank Dr. Madnat and the Graduate School of Public Health for inviting me to come here to speak. And lastly, I am most honored to be one of 2 Latinos, along with Mr. Rigo Vargas, in being here to speak at this forum. Thank you very much.
So at this time, we'll open it up to questions. If you two wouldn't mind, I'll just invite you both up, and then the public can address their questions at either of the speakers. If you both wouldn't mind speaking into this microphone and repeating the question, as that goes to our broadcast and our taping.
Yes.
Well, for both of you, incredible success in your careers, just amazing. So what was it that you took away from San Diego State that contributed to your success? And then, what more should we have done or can we do in the future?
Well, what has contributed to my success coming here to San Diego State, and what more can someone do in the future for us? Well, I got to start with, it was so long ago that I couldn't tell you what we could do to improve, but I would have to say that the classes I took were mostly doing things hands-on. And it wasn't just the book stuff, but the on-hand stuff that really taught you to get out there and be forward-thinking and stepping in front of people and becoming confident in everything you did and what you did. And I think that was the most important thing I learned from that.
I'd like to add that as well. But for me in particular, it was hands-on work experience, working here with Dr. John Elder, Dr. James Salas, and other researchers. I was a research assistant, and so I got to do hands-on work, research in particular. But the most important skill that's helped me professionally was the skill that I gained here at San Diego State University, and that was grant writing. And I encourage all of you to, and basically it's doing research, and writing, innovative interventions, and writing yourself in there for promotions and higher salaries, and that's really what's helped me in my career is that grant writing experience, that I was no longer afraid as others might be of this thing that comes with grant writing, this unknown. And so that was one particular skill. So anything that is college students that you can get a hands-on experience, especially grant writing, and whether you stay in the public health career, in education and social services, most sectors have a need for grant writing experience, so that I really encourage everyone to get as much experience in that sector as much as possible.
Rigo, what should we have done
Yeah. Yeah. No, mhm. So time does fly here. I came here from 91 to 93, so 25 years ago coming up. And so time does fly, and I also...
use that excuse.
Yeah, yeah, yeah. But I can't think of, um, yeah, yes.
You were going to tell us about your trajectory.
Yes. So leaving when I was here working at San Diego State on research projects, I was willing to stay in the beautiful city of San Diego. I was raised in Ventura County. I came to this country as a 7-year-old immigrant from Mexico. My parents actually left. My brother and I are the oldest two in Mexico to be raised for 2 years with our grandparents. And so when my parents got established here, then they brought us to Ventura County. And so education was always an important aspect of our upbringing, and so in coming to San Diego State, my first, I loved coming to San Diego State, and I was willing and was ready to stay and work and live in San Diego, but a grant that we were working on was one of the very few that did not get funded. Dr. John Alger and Dr. James Salas had and have a significant track record in their research, but also in grant writing, and so we were getting a lot of grants, but that one particular one that I was looking forward to working on was not funded. And so I kept my options open, which is another thing that I like to encourage everyone to keep their options open. And so I was looking at possibility of going back to Ventura County where my family had been for years. And so a job landed at a community-based organization as a program assistant, developing community-based programs, public health interventions. From there, I went and worked a year at an HMO doing health education. So I was in the graduate school of public health in the community health focus or sector interest. And so I thought I was going to be a health educator for a long time. But coming into the not-for-profit world, into also the for-profit and the HMOs, I learned that in order to really have a bigger impact in the community, you really need to have some skills also around administration and management. And so those skills I got more and more exposed by having networks, collaborations, and so colleagues at County Public Health 20 years ago invited me to apply for a position entry level at County Public Health, and from there with grant writing that I was involved with, I just moved up the ranks. And 5 years ago, I was fortunate to apply for and compete, and after three tries, after three different openings of the public health director position, I was successful in landing that position. So that's been my career trajectory. It's always been in public health, but I thought again that as a health educator, I was going to be fine. And there's nothing wrong with staying as a health educator. It's just that there's a lot of other opportunities. But I never saw myself as an executive, as an administrator, but just never put your head out there in different jobs. And if you don't get it once, try again.
Not specific to the topic of your presentation, but I have a question about Ventura County. It goes without saying that Ventura County had a very hard year in terms of acts of God. What is the public health system's role and responsibility in the recuperation and the recovery from the fires, from the mudslides, from these tragic events?
Yeah. It's a great question, Benjamin. So, Ventura County, we've first experienced the Thomas fires, and then our sister county, Santa Barbara, with the landslides. So, in public health, one thing that I love public health at the county level is that it's very diverse. We have health educators, public health nurses, microbiologists, physicians, public health nurses, social workers. And so we also have EMTs and our emergency preparedness office, emergency medical services that oversees our ambulance system. So we were very involved mainly in the response all the way from making sure that there was enough response effort, coordinated effort to evacuate the families, and then the shelter, doing public health checkups, releasing advisories around safe water and air and distributing almost 600,000 masks to folks because especially city of Santa Paula and Ventura, there was a great amounts of smoke. And so we were mostly involved with the response, but in the recovery, we've been monitoring the health conditions of the community. We were at the Department of Center with the operations coordinating efforts. So we've been at the table, but mainly was in the initial response.
So when I started, there was 7 jobs for every PA. And that number has slowly dwindled, but there's still jobs there, mainly because it's driven by health insurance. As health insurance costs rise and you need more health extenders, physician assistants and nurse practitioners, there's always a need for them because they can provide the same amount of services and not cost as much for the cost of insurance. So there's always positions filled or needed for physician assistants and nurse practitioners. So that field is always growing, and the number of programs that have popped up all over the country has been increasing exponentially as well. So there's always a role for health professionals in that field, without question, in the next decades that come.
Thank you. So the question has to do with what can we as public health professionals do to further engage, especially the young people, in public health interventions. And that's really the key is actual engagement, true, genuine engagement to bring them to the table and help them identify what really is the situation in their community, and also solicit their input in the design of interventions and in the delivery of some of those interventions. So really building trust with communities. Oftentimes, some communities are leery of public health professionals, especially if they come from research institutions or universities, thinking they're just going to come in and deliver a program and then leave, and then also using more of the pulpit and saying, you should do this or you shouldn't do that. But it's really engaging them and bringing in their talents, their skills, and working within the positive things that are going on in these communities, including youth. Of course, youth are very innovative, very savvy, especially with social media. So really engaging them and meeting them where they're at, and really listening to what they have to say and seeing how you can develop programs around their input, I think, is one of the keys. Mm-hmm. Thank you.
Okay, I think we're all set. Thank
Okay.
you very much.
Thank you.
Well, thank you so much. This was a real pleasure to hear from both of you. We're happy to claim you as San Diego State alum, and thank you very much. So I wanted to say a couple words, this being the next to last GSPH Student Success Fee funded piece. For 20, we have one more small one that's going to replace one that didn't happen, and so that'll happen in this building. I want to say a note about the Student Success Fee program. It's an amazing program that San Diego State University has made available to student organizations to bring excellent speakers, and in this case, alum of this program, and so we can hear about their lessons learned, their experiences, their successes and trials and tribulations, and this was a perfect example to hear tonight from two wonderful folks from San Diego State. I also want to mention that the work of the GSPH Student Council this year has been fantastic. They have put together an amazing slate of student success fee presentations, and these are captured by KPBS and are archived, I believe, on the web. And so this is a continuing a thing that people can continue who aren't even here to see tonight's speakers and the previous speakers. So I want to congratulate the GSPH Student Council on a really successful year. So I think it deserved. And of course, Dr. Madanat for leading us in that process. So I'm sure our speakers will stick around for a few questions. Sorry? Oh, thank you. Yes. They're somewhere here. Yes, of course. Of course. Our cuppeth runneth over with, we'll fill it with something. It's with gratitude. Our cup runneth over with gratitude. So you can't leave without some swag from the Graduate School of Public Health. So come back up here, please. And this is a little swag that you can take back home and to your office or home. And if you're a coffee drinker, if you don't like coffee, that's fine. It can be filled with tea or water. Those are Graduate School of Public Health mugs, and so you can always think about us when you go back home and whenever you're back in San Diego. So
very grateful. Thank you. Thank you. Thank you.
And that concludes tonight's program. Thank you so much for coming.